Confesc. David Andersson did his PhD studies in Lund, Sweden. It led to the identification of endocannabinoid lipids, undermined and secondary clinical glycerol as the first endogenous agonist of TRPV1. After moving to King's College London, his work included the identification of endogenous agonists and modulators of TRPM8 and TRPA1, and identification of TRPA1 as the target for paracetamol. He was awarded the first London Law Trust Medal and Fellowship. More recently, his lab has performed pioneering studies on the role of immunoglobulins as the cause of pain, the pain syndrome CRPS, and fibromyalgia together with Andres Goff. He has a huge interest in chronic pain.
So good morning, David. Thank you very much for agreeing to be interviewed for this event that will be celebrated with a National Patient Association for Fibromyalgia and ME/CFS in Spain. And they have some questions regarding this recent publication of your group, which is very exciting findings that you reported recently in the Journal of Clinical Investigation. And as a start, they would like that you provide an overview of the main findings of your study.
Yes, so the most important finding is, of course, that it seems that many, or indeed all types of symptoms that we feel we are able to assess in mice seem to be transferred when we administer antibodies from patients. So when we purify antibodies from patients and inject them into mice, we can demonstrate that the mice are hypersensitive. So they have mechanical hyperalgesia, cold allodynia. They have a relatively quick onset of muscle weakness. So they have reduced grip strength and they move less. So we are still not quite sure whether the reduced activity level is an index of pain or fatigue, but we are obviously spending a lot of effort to be able to discern whether the antibodies also cause fatigue. Fibromyalgia is associated with a loss of innervation of the epidermis in a large subset of patients. And when we inject antibodies from patients to mice, we also observe this reduced level of epidermal innervation within 2 weeks. So we think that we demonstrate that actually it seems very likely that the bulk of the key symptoms of fibromyalgia are caused by antibodies that act in the periphery throughout your body, rather than by being a primary disorder caused by altered circuitry in the brain. And to me, this means many things, but first of all, it means that we can start really think in more detail about how to treat the condition. We can also start to really have a good design strategies for designing diagnostic tests. And finally, I think it should mean a lot to many patients, since fibromyalgia has been a condition surrounded by some doubt or even stigma, where patients don't feel they are believed by the surrounding, by the state, by their employers, and sometimes not even by the doctors or clinicians. Here we can demonstrate that we have a biological, we think, somatic cause of the disease, and if nothing else, that should validate the experience of patients.
Absolutely. So what were the reasons that drove you to start this study? Why looking at fibromyalgia?
Well, we were looking before at complex regional pain syndrome, which is far less common and it's a slightly unique condition in many ways. It's post-traumatic, but there we found very similarly that antibodies from patients produced painful sensitivity in mice, but only if they'd been exposed to an insult. So it seemed something in the inflamed or injured environment. In this case, it was a very small surgical incision. Allowed antibodies from patients to produce painful hypersensitivities that lasted similarly for at least a few weeks. So we started to really think hard about what other conditions this could apply to, and fibromyalgia stood out because, like many well-established autoimmune conditions, it's far more common among women than men. Usually we give a number, say four female patients to one male. And it's also far more common among people that have a diagnosis of an autoimmune rheumatological condition. So we thought it seemed likely that fibromyalgia shared some common mechanistic basis with the autoimmune conditions that patients, in addition to fibromyalgia, also suffer from.
So what would you say was the most challenging step in the whole study?
Actually, to publish it. It took almost 2 years from first submission to getting it accepted. And I think there's a very strong, I suppose, paradigm or cultural dogma that states that fibromyalgia is a disorder of the brain. And when faced with questions to demonstrate whether or not particular abnormalities in the brain are present in the mice or are responsible, it's not easy to design experiments to answer those questions. So I think the publication process was perhaps the most challenging. And we tried to, instead of trying to address the current dogma directly by re-examining it, we followed the findings that we made in the lab, and to approach it without bias, hope, or prejudice, but simply to see what happens when we inject antibodies. And it turned out that it seemed many or most symptoms of fibromyalgia were in fact caused by the antibodies.
So after this work, do you plan to continue your research in fibromyalgia? And if so, what would be the next step?
There are many questions that remain. One is, first of all, of course, what do the antibodies bind to? And we've tried several approaches, and we're trying new approaches now. We've tried a peptide screen, which wasn't very successful. So we're thinking that it's more likely to require the normal natural conformation of a protein, or perhaps some modification for the recognition by antibodies. We obviously want to, in some way, test whether removing antibodies from a small group of patients would improve symptoms. So far, this has been done in 2 patients per plasmapheresis, and both had a really sharp reduction in pain and sharp reduction in fatigue for about 2 months. Now, plasmapheresis isn't a trivial treatment, so it's very difficult to say placebo played any role in this. We haven't been able to perform plasma exchange with a sham group, but we are exploring both plasmapheresis and perhaps other therapies. This is in collaboration with Liverpool.
I see.
Andreas Goebel.
So, well, this comes to then another part of questions that I received. And this is regarding the similarities, overlaps between fibromyalgia and chronic fatigue syndrome, since you mentioned fatigue as well. And since there were these rituximab clinical trials to remove antibodies, to block the cells that produce the antibodies. So what is your opinion about, for example, having a similar situation in ME/CFS? And also, what is your opinion about the results of the rituximab clinical trials?
Yeah, the rituximab clinical trial, at least superficially, looked like a disappointment. But not all antibodies come from cells targeted by rituximab. So when you treat the patient group with rituximab, I think less than half experience hypogammaglobulinemia. So many patients treated with rituximab clearly still have an ongoing production of antibodies from other cell types than those states of differentiation, than those B cells targeted by rituximab. So I think it's worth re-examining some of those findings. We are hoping to perform similar experiments shortly. we haven't got any firm results at this stage. And also fatigue is slightly less straightforward to monitor in mice. Don't really know how fatigue is displayed in a mouse compared to a person. We expect it, of course, to be altered levels of activity and perhaps altered socializing patterns, altered feeding patterns. But we're exploring that now.
Okay, so here comes the question also from the participants, the cohorts that you have explored in your study. Some were at the beginning individually tested, right? And then later you have these pools from other donors, from other geographic location even. So were these patients at some point also diagnosed, co-diagnosed for ME/CFS or not?
These haven't been, but I'm not sure that would really impact on the findings that the antibodies produce. So far, we haven't come across any patient that has appeared inactive in the passive transfer experiment. To reduce the complexity of our results and perhaps also the interaction with reviewers, we avoided to include patients with comorbid diagnosis. But clearly, some of the patients primarily suffered from fatigue and many from pain. So we had, so both, I suppose I am perhaps sometimes guilty of seeing fibromyalgia and ME, since they're both diagnosed entirely based on symptoms, as similar disorders on a spectrum with different balance of symptoms rather than, we haven't shown that yet, but we hope to establish whether ME/CFS is caused in a similar way. So we don't think any of them actually qualified or had been qualified for ME/CFS, but we can't rule out that some could be. Many of them had fatigue to quite a severe extent.
So you wouldn't think of applying this same approach of the mouse model with IgGs from other conditions, not only ME/CFS, but for example, other chronic pain diseases, or even a group of autoimmune rheumatological conditions?
So yes, we are hoping to have results on ME/CFS before too long. And we are also thinking about other conditions that we think are likely to be caused in the same way. And our collaborators in Sweden at Karolinska have long studied the pain in rheumatoid arthritis caused by anti-citrullinated peptide antibodies. And that was, and it obviously looks persuasively similar.
Okay, so this is interesting that perhaps the model that can be derived from your study, it's a closer model to the disease itself than the ones were so far available for fibromyalgia, and perhaps from other diseases as well, right?
Yeah, we have been reluctant to use the established models because I think they're very severe on mice. They often involve restrained stress and cold exposure and so on. And there's also been repeated injections of acetic acid into muscle. Now, I just don't see that, although the mice may display symptoms that are similar, it's very difficult for me to think that there's any construct validity that injecting acetic acid into the muscle would have anything mechanistically in common with fibromyalgia or ME. It seems highly implausible.
That's right. Yes. So also regarding differences between patients, have you done or are you planning to interrogate men suffering from fibromyalgia, from women suffering from the same disease with your model?
So we have used samples from 2 males so far. We don't see we haven't seen any overt difference in the results. We haven't detected any difference. So we think it applies to male and female patients.
Yeah, yeah. I saw in your study that you also used male and female mouse
Yeah.
to also evaluate these.
Yeah.
So it's like from both angles, right? That you approached.
So we've used male and female patients, but obviously predominantly female patients. We've only had 2 so far of males.
Mm-hmm.
We've tested the effect of female antibodies in male and female mice, and we don't see a difference. So we think it seems to us that the symptomatic presentation really is inherent to the IgG itself.
Yeah. Also, have you looked at the immune system of the mice that were treated with IgGs injections? Other than the isotype composition, did you see any other, or are you planning to look at any other changes?
This is for future planned experiments, but of course we're interested to see whether the antibodies influence the immune system. Yes, we haven't yet. We haven't got results yet.
Yeah.
We don't see any of the major cytokines change, for example. So they seem to, at least in circulation, cytokines and chemokines seem to remain relatively unaltered. That doesn't mean that they're not changing somewhere, but not in circulation.
That's right. Well, I received a question from a patient that maybe many other patients may have too, and to her it was it seemed contradictory that some therapies recommended for pain involve intravenous IgG therapy injections. So she was asking if we have a problem with our IgGs, how can we improve for getting more IgGs from outside?
Yeah, it's a funny therapy, but I agree, it's very counterintuitive. I have my own view, and I think it's probably becoming quite established on how it works. And I'm not an expert in this area, I'm not an immunologist, but I assume that we dilute out our own IgG and therefore shorten the half-life of it. So by injecting large amounts of healthy IgG, will remove much of the patient's own IgG from circulation. And so that would be a therapeutic principle similar to plasmapheresis, but without altering the levels in circulation.
Yeah. Okay, and also it's so interesting that you get the satellite, the antibodies from fibromyalgia patients binding to satellite glial cells. So wonder if, since these cells are cells that are in charge of regenerating sensory neurons, wouldn't you expect to have other symptoms, like, for example, the loss of smell that is happening with COVID infections?
We haven't examined any of the cranial nerves. So whether we see the same pattern in trigeminal or any of the other cranial nerves, we don't know. They may not be identically affected. We should also be slightly cautious we are very excited by the pattern of binding to satellite glial cells, but we haven't so far demonstrated any link between that binding and the symptoms. So it seems very plausible and persuasive that it would be the case. We haven't demonstrated that there's a functional consequence of that binding. Sensory function. And also we don't see any damage to the cells. We don't see a loss of satellite glial cells. Also satellite glial cells, they're interesting for any number of reasons, but for me, not least because they're not that well understood. So it guides us to an area that isn't well explored, and it leaves a lot of work to be done.
Yeah. So would you think also to use this model, this approach to long COVID patients?
Yeah, this is a question that we have received several times. And we are planning to do that. And it's taken slightly longer than we hoped to get hold of samples. But as far as I see it, fibromyalgia is entirely blind to the cause of the disorder. So it's a diagnosis based entirely on symptoms. And since quite a number of the patients with long COVID actually qualify for fibromyalgia diagnosis, it seems very plausible that they would also have a similar mechanistic basis. And we know from very elegant studies from Yale that the patients that have recovered from the COVID infection have a wide repertoire of functional autoantibodies. And it seems that they define the severity of the disease. So during the infectious phase, those that have antibodies against certain interferons seems to be more severely affected. We also know that they produce many patients who have recovered from COVID infection have autoantibodies against proteins in other tissues and organs. So yes, we are very excited by the prospects.
Well, this is very exciting too, and very encouraging for the patients to hope for a new therapy, I guess, because once you have the model and you know what is the underlying mechanism, then you can try approaches to fix that, to fix what is wrong. So it is wonderful, all the work that you're doing and all the plans that are to be expected from the next experiments.
It's a busy time.